One of the first things we do in an examination is active range of motions. We're going to ask a patient to go through a number of ranges of motions. You never direct people to tell them to touch different points or places, i.e., do me a favor, bend over and touch your toes. You suggest, do me a favor and bend as far forward as you comfortably can as if you're going to touch your toes. This will allow them, it'll prevent them from getting sometimes undue pain, as patients will try to do as you ask sometimes, even if it means causing them a little bit more harm. Right? There are a number of things that we're going to look for in active ranges of motion. We're going to look for global ranges of motion. Now you're going to learn in an FAP class to do this using inclinometers. Right? I'm going to give you some visual cues as to what's relative normal while you're performing science. We're going to look for segmental ranges of motion. I may be able to bend over and approximate my fingertips to my ankles, which would imply my lumbopelvic ranges of motion are normal. But where's the motion really coming from? Many times people can bend over and touch their toes, and I can actually, most maneuvers coming from the hip itself, but the spine is not opening up. So we're going to look for the spine proper. Fluidity of movement. People should do things with ease. Just the fact that I can approximate my chin to my chest, there's a big difference between being able to do it effortlessly or those that do it, okay, 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 okay. In both, I've demonstrated my global range of motion is relatively normal, but I wasn't doing it very fluidly. One of the other things we're going to direct patients is, while you're performing this maneuver, if you have any discomfort or pain, please let me know. So if they do complain of discomfort or you see visual angst per se, one of the things we want to do is just don't note pain. We're also going to ask for the location of that pain and the quality. And the reason being is, if I have pain and extension, there's a big difference on the etiology if I say it's sharp and deep at the base of my neck as opposed to it's stretchy in the anterior aspect. One implies we could be joint because we're putting the joint capsules into a closed pack position. The other implies myofascial. So I always want to follow up with where they experience it and what is the quality of it. And then I'm going to just direct you to some of the things that we may say. On your form here, you're going to see something I call, which looks like the Blair Witch Project. What we're going to do is we're going to look for global ranges of motions and make notations on those. We're also going to record the quality of pain and segmental rotation. To understand this, it's probably best to visualize if you're looking straight down on a person's head. And if this was their nose right there, you would see that this is the sagittal plane, flexion and extension. This is the coronal plane, left or right lateral bending. And this is the plane that we use when we use for left or right rotation. Okay. So the first thing you have to understand is these two over here we'll look upon is as orthopedic tests, just as kind of a general view of something. So we'll get into those in a little bit of movement. So let's look at cervical active ranges of motion. Cervical active ranges of motions, you can just direct your patients to say, I want you to do a few of these movements. You can follow me if you like. Just let me know if there's any pain or tenderness. Okay. Flexion and extension. Do me a favor. Can you bend your head as far forward as you comfortably can, as if you're trying to approximate your chin to your chest? They should move fluidly. They should move effortlessly. They should have no pain. And they should roughly be able to approximate their chin to their chest. If you feel that their movement was full, I'm going to go to the action of flexion, and I'm going to draw an arrow at the end of that line as it measures that they were 100%, they had global range of movement, 100% global range of movement. But let's say during the notation, all they could get was about to here. Well, that's as far forward as I could flex, and that's about 50% of what I should demonstrate. Therefore, in this case, what I would do is I'd take the arrow and look at this as being 0, and this as being 100% of ranges of motion, expected ranges of motion. Since they had about a 50% deficit, I would bring the arrow to about the 50% mark. So the arrows go relative to the percentage of full range of motion. And again, so 10%, I may place it here. 25%, I might place it in there. Do me a favor. What I want you to do is bring your head back, reach your head back as far as you can. It's like watching an airplane go up overhead. Have the patient look up. Now, normal global range of motion would be, I should roughly be able to get my face to look somewhat parallel to the ceiling. Okay. So in this case, once again, if I was 100%, I'd put the arrow all the way at the end. Now I had a little bit of pain and discomfort on this one. So to that end, you would ask me, any pain or discomfort? I would say, yes, I did. And we asked the location. Could you show me the location of this? And I would point right back to the base of my neck. And if you asked me what it felt like, I'd say it would be sharp in quality. You want to follow up and say, in terms of severity, is it mild, is it moderate, or is it severe? Well, mine was relatively moderate. We denote pain in whatever motion that they had, and we would denote this following. 1 hash mark would be mild, 2, moderate, and 3 would denote severe. Mine was moderate. I would make 1 slash, and then I'd also make a notation to myself that for the most part I had on the base of C-spine, and I could locate approximately C6, C7, and that it was sharp in nature. So I can make those notations right on a mark. Okay. Now while I'm doing extension, as we set other down over here, one of the things you may want to take a look for that you learned in Dr. Michael Hall's class is, do you see cervical collapse? I may get normal ranges of motion. My head may appear somewhat parallel to the ceiling. But if I have normal extensor mechanisms, my ear hole, my EIM, should go posterior to the plumb line. It should not drop straight over it. If you see dropping straight over it, that's an indication of cervical collapse. And once again, I'd make a notation here. Cervical collapse for myself. For lateral bending, do me a favor. I'm going to have you bend your head to one side and then the other, as if you're trying to touch your ear to your shoulder. You should be able to get about 45 degrees, looking at this is 0 and this is 90. I should be able to get to about 45 degrees and be symmetrical on both sides. Now the thing you have to watch out for is compensation. You will record their active range of motion to where you first see compensation. So for example, I may be able to get here roughly as being 45. But in the course of this, as I laterally bend and you begin to see me drift my shoulder up, I'm beginning to compensate in order to complete the move. So you would really only record me. If this is where you see my shoulder begin to kick up, this is my active range of motion, which is about a 50% reduction. So I would note it, since I was going into, in this case, into right lateral bending, I would note my arrow here. Once again, is there any pain or tenderness here? Well, to tell you the truth, I did have a little discomfort. We always go to, well, where did you feel it? I felt it on the lateral aspect of the left side of my neck. What does it feel like? In this case, mine feels stretchy. It sounds a little bit more myofascial. So in here, I wrote my pain was mild, and that I experienced on the left scalenes, and it was stretchy in quality. Some other compensations that you may look for, you may begin to see people begin to rotate their head as well. No, 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 no. Their range of motion is only that which they can do in that plane of field. Okay. Next would be cervical rotation. Do me a favor, I'm going to have you rotate your head to your right and to your left. You should be able to get roughly your head in the same plane as your torso. Okay. Anything less than that would be a percent decreased off of your rotation. That would bring full right rotation. And once again, begin to look for compensations. A lot of people, when they begin to rotate, they also begin to laterally bend and extend their head to that side to fulfill the movement. Where they begin to compensate is a measure of their active range of motion. Followed up by, do you have any discomfort and or pain while performing so? If so, can you show me where the location that you feel, watch where they mark, and what is the quality of it for active ranges of motion? Now, as an aside, I don't have somebody here to palpate, but just because we're doing active ranges of motion doesn't mean we have to stop at that. Let's say, for example, if I have them watch them do active ranges of motion to one side and the other, and I notice they have limitations. I have to ask myself, it could be joint. Well, to this we're going to look at segmental range of motion, which I'll get into in a minute. It could be myofascial. If you're thinking myofascial, just ask yourself, if I'm laterally bending, in this case to the left, what muscles, what soft tissues would oppose that motion? In this case, predominantly, it would be the lateral musculature on the opposite side. To this end, you can do what's known as selective palpation. I can passively laterally bend that person to the side of percentage difference as I selectively palpate the soft tissues that might oppose that movement. The tightest of the musculature, those muscle bands are the quickest to pop, and therefore you can begin to look into your soft tissue techniques. For example, in Dr. Bob's class, you learn there's some techniques such as Graston techniques that are designed to break up myofascial adhesions. So this might become, again, you're always thinking about what is going to be in your treatment plan, and this is where you can add this in. One of the things we haven't got into yet is segmental range of motion. And this is one of those things while it's probably best to be in a position while they're doing this to where you can actually physically look at the spine. For example, when I laterally bend to the right and the left, while I might have relatively normal ranges of motion, 45 degrees, what I want you to do is look at the spine. If all the motion segments that comprise the cervical spine are working well, from the upper thoracic spine right up to the occiput should be a beautiful, beautiful, non-interrupted curvilinear arc. It implies that all the segments are functioning properly. Sometimes you may have people, for the most part, they can laterally bend fully, but their neck looks like this. The upper thoracic spine looks straight as an arrow, followed by a period of what appears to be almost like a 90-degree bend, which is basically a measure of hypermobility, and it might be followed by another area that's relatively flat and straight instead of curving. In essence, you can almost see the segmental problems that they have in their joints, and 9 times out of 10 when you go there and follow up with your motion palpation techniques, this is exactly what you're going to find. But this would be an indication of while their global range of motion might be full, they have a decrease in segmental range of motion. Well, how would we record that? Well, let's say when I'm doing lateral bending, let's say in this case in left lateral bending, I'm full. But you notice that instead of my spine forming this beautiful curvilinear arc, there's a place in the upper thoracic spine that is rigid. It doesn't bend at all. In this case, I make a notation over here. I have a decrease in SROM, segmental range of motion, and I'm going to eyeball it between C7 and T2. When you flex forward, the whole spine should open up. Once again, you may have full range of motion, but you notice there's a part of the spine that doesn't open up or bend forward. I would note a decreased segmental range of motion, eyeball the region that you see it in. Okay? And this is going to take us through the cervical spine. For the lumbar spine, it's the same thing. Once again, this is flexion and extension in the sagittal plane. This is lateral bending. And this is rotation. I'm going to direct my patient, do me a favor. I'm going to have you bend forward, far forward as you comfortably can, as if you're going to touch your toes. The normal range of motion, although you can't see here, I should be able to approximate my fingertips to my ankles, in which case I did. I have full range of motion. I did not experience any pain, so I do not make a hash mark on that. But if you were to run your hand down my spine, you would find that between T10 and about L2, my spine doesn't open up and bend forward. As a matter of fact, it almost stays cupped. So in this case, you would record that I have a decrease in segmental range of motion roughly between T10 and L2 while performing flexion. With extension, you can place your hands on your hips, bend back as far forward as you comfortably can. This is more of a visual. There roughly should be 15 to 30 degrees the angle of my torso relative to my pelvis. If you notice a decrease, you say, well, you're about 10% reduction. So on my line here, I take about 10% is where I make my arrow. Do you experience any pain or discomfort? Well, to tell you the truth, I had a little bit. Where did you feel it? Roughly in the lower thoracic spine is where I feel it, and it was pretty sharp. Would you say it was mild, moderate, or severe? In this case, to tell you the truth, moderate. Because it's moderate, I place 2 hash lines to signal moderate pain with a notation of I felt it in the thoracolumbar spine and it was sharp in quality. With lateral bending, do me a favor, keeping your arms at your side. I want you to bend both to the right and the left side, as if you're trying to take your fingers to the mid position of your knee. Touch your fingers to your knees. Slide your hands along your sides as far as you comfortably can. Normal global range of motion would be roughly, I should approximate my fingertips to about the mid position of my knee. So I'm full on both sides with no compensation. This is where, once again, you always want to be looking at the spine, and it's best to watch this from behind, because from the pelvis, from the lumbosacral junction, all the way through the thoracolumbar spine, once again it should form a beautiful, non-interruptive curvilinear arc. If you see any areas of flattening, that would be considered a decrease in segmental range of motion, which I would make my notation the same as I did with the cervical spine. T10 to L2. If I had discomfort and or pain, once again I'd ask you, is it mild, moderate, or severe? Well, mine was mild. And what did it feel like? It was sharp in the region of the thoracolumbar spine, this time on my left. So ask yourself, what could be happening here? Well, when I laterally bend to the left, I know that I'm causing closed pack position of the facet joints on the left. That could be sharp because I'm putting them in a closed pack position. So once again, you're always thinking with these things. Just don't take the information and let it go. Take the information, look at it. How does it correlate with what you found? In other words, your postural analysis. You're always correlating them. With rotations, the problem with rotations is I have to make sure that the rotation I'm looking for comes from the torso and not from the pelvis. There are a couple ways that you learn to do this in class. One was to have the patient bend over, and then from there, rotate one side the other. Another simple way is to have them sit down. This locks the pelvis. Have them rotate their torso as far as they comfortably can. Normal global ranges of motion would be, my torso should be 45 degrees relative to my pelvis. That would be full. As they go through it again, just ask yourself, did they move fluidly? Did they compensate? If they did compensate, you would mark it accordingly. It's where they begin to compensate is their active range of motion. Do they have any discomfort or pain? If you do, if so, tell me, can you show me where you feel it? What does it feel like? Last but not least, we always look at segmental range of motion. When you're looking at the spine during rotation, what you really should see is a subtle, beautiful, non-interrupted spiraling arc. I call them ladders. I should see, instead of a spiral, sometimes when you see a decrease in segmental range of motion, you don't see a spiral, you see a ladder followed by a spiral. And that would indicate a decrease in segmental range of motion. You would note it in whatever range of motion that they had it, and you'd ballpark the region that you see it in. And these are some of the things to look with active ranges of motion. These final two symbols here, whether they be the cervical spine or whether they be the lumbar spine, you could look at them as being just orthopedic tests. In the lumbar spine, this would be a seated Kemp's test. So in other words, I would take this individual on my right, and I would bend him over, back, extend, laterally bend to the right, and then to the left, asking this to cause any increase in symptoms. If it did, I would say this would be positive for those findings, and if they did not, I would say it would be negative. The same thing applies to the cervical spine. You're going to put them in maximal foraminal compression and ask them if they have any discomfort and/or pain, and just do the same. And that's what these two lines indicate. But these are some things to look at with active ranges of motion.